Okay, well, we want to welcome everybody today to our webinar. We are so excited to have you join us. My name is Yvonne Alsop. I am a member of the School Health and Wellness section at APHA, the Professional Development Chair. And we are partnering with the Public Health Education and Health Promotion section to present this webinar to you. We have three wonderful guests, and our focus is going to be on measles, things that we're seeing in, this year. So, with that, we want to invite you as we go through this webinar to save any questions. Please send them to me in the chat directly or just put them in the chat and I will monitor them. We will hopefully have some time at the end to go through that and hear what these wonderful individuals have to say. And also, as a reminder, feel free to claim this as a Category 2 CHES credit. We can put in the chat here for you the link to the web page you can go to get that form if you need to do that. But we love learning and we love things related to learning about public health and continuing our knowledge with that. So by the end of our session today, by the end of our time together, our hope is that all of us will be able to better discuss the epidemiological spread of measles and where to obtain disease updates, especially with what is happening here in our own country, and also to identify various communication tools and strategies for communicating about measles and the benefits of vaccinations to various populations. We also hope that everybody will leave being better able to discuss various tips and strategies for using opinion editorials as a health communication and education tool for parents, schools, communities, and policymakers. So we are just going to dive right into it, but we have our three wonderful speakers for us today. So first, we would like to introduce Dr. Catherine Troisi. She is so wonderful. Just chatting here, it's just been a delight. But she's a professor of management, policy, and community health and epidemiology at part of the Texas and also part of the Texas Epidemic Public Health Institute leadership. She's at UT Houston School of Public Health, and she's a co-editor of the Control and of Infectious Diseases manual. And most importantly, she's an infectious disease epidemiologist. So we are going to pick her brain about measles today and learn from her. And we have Amanda Kwong joining us as well, who is the director at Public Health Communications Collaborative. So we're looking forward to all that she has to share with us. Additionally, we have Dr. Stephen Gambescia, who is a professor and the director of Doctor of Health Science program at Drexel University, joining us as well. So what we are going to do today is each individual will have 13 to 14 minutes to share with us their knowledge, and we will get to learn from them, and then we will have an opportunity for Q&A with time left over. So with that, we will turn our time over to Dr. Troisi.
All right, thank you. Welcome, everybody. And I'm going to give you a short either introduction or refresher to measles epidemiology, some of the clinical data, what it looked like in the past, and why are we seeing this outbreak in my home state? Actually, not my home state, but where I live now. Next slide, please. Okay, so you all have probably heard that the measles virus is one of the most infectious viruses, if not the most, that we know of. The R naught is between 15 and 18. That means that each infected person can infect up to 15 to 18 susceptible people. And if you think of it another way, if susceptible people come in contact with a case, 9 out of 10 of them will become infected. One of the reasons it is so infectious is that it can stay in the air for up to 2 hours. So you may not even know you've been exposed. Somebody with measles goes to the grocery store, coughs is spreading, and you can be infectious before symptoms occur, again, making it more easy to spread. And that person does their shopping, leaves, you come an hour later, you do your shopping, you have now been exposed. So again, very, very infectious. There are no animal reservoirs, which is important for elimination. In fact, we used to talk that after smallpox, we were going to eradicate polio, and next was measles. I don't think anybody's saying that anymore. Luckily, we do have an effective vaccine, and it is a live attenuated vaccine. And I'm sorry, you may be able to tell the weather is gorgeous here in Houston. What that means is there's yellow pollen over everything, and my allergies are terrible, and hence I'm losing my voice. Okay, so we have an effective vaccine. If you get one dose of this live attenuated, that means weakened vaccine, 93% of people will be protected for life. If you get 2 doses, it's up to 97%. It is the gold standard for vaccines. It is very safe and very effective. Now, so who needs this vaccine? If you were born before 1957, the assumption is you had measles because every child got it by age 15. And so there's no recommendations for vaccines. The vaccine came out in 1963. We had an earlier version of this vaccine up until 1969 that wasn't quite as effective. So if you happen to have been vaccinated during that time period, a dose of the current vaccine is recommended. If for some reason you received 1 dose of the current vaccine, a second dose is recommended. And then, that little thing, that Ask AI assistant, was blocking part of the chart, but we do have post-exposure prophylaxis. You can be vaccinated up to 72 hours after exposure and still have a fairly good chance of being protected. Also, because we can't vaccinate babies under 6 months, and we don't like to vaccinate them under 12 months because maternal antibodies can interfere with the response to this live vaccine, there is immunoglobulin available. And in fact, you may have read in the news that there were some babies exposed, and they are getting immunoglobulin. Okay, so it used to be measles was everywhere, but it is not benign. Symptoms usually occur 7 to 14 days. It can be a little shorter, a little longer after infection. Starts with a high fever, cough, runny nose, itchy eyes. That can be a lot of viral illness, right? And so it may not be diagnosed as measles right away while you're infectious. But then you start getting this distinctive red rash that starts from your hairline and moves down the body. And in your mouth are what are called Koplik spots, and they are very diagnostic of measles. There are no antivirals available, and so the only care is really supportive care. Vitamin A has been shown in countries where vitamin A deficiency is more common to protect against some of the sequelae from measles. In the United States, only about 1% of the population is vitamin A deficient. So despite some recommendations you may have heard, vitamin A is not necessarily recommended. And if it is recommended, it needs to be taken under the supervision of a healthcare provider because, again, as you may have seen in the news, there have been overdoses, with vitamin A, some liver conditions because of too much vitamin A. So, as I said, it's not benign. 1 out of 20 people with measles have to be hospitalized. And that number is higher if you are younger, particularly under age 5. 1 out of 10 will have an ear infection. 1 out of 10, maybe a fewer number, get diarrhea. 1 out of 20 will get pneumonia. And in fact, in younger ages, that's the usual cause of death is pneumonic disease. It can cause deafness. 1 out of 1,000 will suffer from encephalitis, and usually we see that in older age groups. There's a rare, you can see 7 to 11 out of 100,000, neurological disease called subacute sclerosing panencephalitis that shows up 7 to 10 years later after the infection. And it usually leads to death. And then 1 to 3 out of 1,000 cases will die. Excuse me. So who's at higher risk? As I said, children, all right, I may need to get a cough drop. Children under the age of 5 are at highest risk, as well as adults over age 20 years, which is unusual because usually we say over 65, right? But measles can be severe even in this younger age group. If you're pregnant, there can be severe consequences. And then if you're immunocompromised. So I told you we had a very effective vaccine. Pregnant women can't be vaccinated if they haven't gotten it before they got pregnant. And immunocompromised can't. Babies under age 6 can't. We don't like to vaccinate those under 12 months. So there are populations that are at risk that we can't protect with the vaccine. Next slide, please. The next slide, please. All right, so you may not have heard about measles for a while because in the year 2000, with this effective vaccine, with good immunization campaigns, measles was declared eliminated from the United States. So on the left, you can see cases from the far left-hand side is right when the vaccine came out. We used to see lots and lots of cases. There were 400 to 500 deaths every year in children from measles. And it's not easy to predict who's going to die. The 2 deaths that we've seen so far, spoiler alert, the 2 deaths we've seen so far in children in Texas, they were healthy children. But so the vaccine came out in 63. Look at that drop. Now we have seen outbreaks. And in fact, in 2019, we had a very big outbreak in outside New York City. But we've done a fairly good job controlling measles. If you want to look at it another way, on the right-hand side, it shows you the rate of cases measles per population, because obviously it varied over that time period, and deaths. But again, showing tremendous job controlling measles in the United States, not necessarily true globally, but in the United States. Next slide. All right, so what's happening now? Oh, I forgot to check. I don't know if the data from the Department of State Health Services, DSHS, has come out yet, but this is as of last Friday. In the US, we have seen so far 607 cases. You can see the age distribution, and you can see that most were either unvaccinated or we don't know whether they were vaccinated or not. We have now seen 3 deaths, the 2 children in Texas and 1 adult in New Mexico. Now, I will say that the accounts vary on the person, the adult in New Mexico. I'm going to say he, I don't know whether it was he or she, died with measles. It is unclear whether the death has been attributed to measles, although some places are making that assumption. We're seeing a lot of cases around the United States. 22 jurisdictions are seeing measles cases. Canada is having a very big outbreak right now of measles. So in Texas, since the first cases on January 20th were reported, we are now up to, at least as of last Friday, up to 481 cases. It has spread to New Mexico. It has spread to Oklahoma and perhaps to Kansas. That's still a little, I mean, they are definitely having cases. Whether it's linked is not clear, although probably so. We are in danger of losing our elimination status. Once an outbreak gets started, it's hard to stop if you have people who aren't vaccinated, who are not protected. All right, next slide, please. So one of the concerns, because we are seeing increased hesitancy about vaccinating children, measles is a harbinger because it's so infectious, but we are seeing other vaccine preventable diseases this year. We've had 2 deaths in Louisiana from pertussis. We've had 4 times the number of pertussis cases since last year. We've seen, as you can see, we're seeing mumps, we're seeing chicken pox, and then seasonal influenza. It's pediatric deaths that are reported, and there have already been, as of the end of March, 159 pediatric deaths, which is, it's just very, very sad. Next slide. So why are we seeing these outbreaks? Well, as you probably guessed, it's due to vaccine hesitancy. And you can look on the left-hand side on that map. It shows you MMR vaccination rates. Some states have higher rates than others, but there are many states where the vaccination rate is less than 95%, which is what is needed for community immunity for measles. And I have to add a caveat there that you can have a county, say, where the overall vaccination rate is 95%, but there are pockets, a lot of times schools, where the vaccination rate is lower. And so measles can spread in that school, even though the overall immunization rate is what we consider necessary to stop community spread. We have seen, well, for a while, but particularly since the pandemic, an increase in vaccine exemptions. So there are only 5 states where only medical exemptions are allowed, and one of those states is trying to reverse it. But if you look at the other states, a third of them have some requirements, which may only be a notarized statement that it goes against the parents' personal beliefs to vaccinate. Some states, like Texas, it doesn't even have to be notarized. So it's not just religious exemptions, it's personal exemptions. And as I mentioned, since the pandemic, we've been seeing an increase in these exemptions. And if you remember that slide before, we are seeing the results of kids not getting vaccinated. Next slide, please. So I do a lot of media interviews on measles, and one thing that I'm often asked is, when is this going to end? Well, you know, I don't have a crystal ball, but outbreaks usually last between 2 and 6 months. However, they can last up to a year, up to 12 months. And really, it depends on how many people are susceptible in the population and how they congregate. You know, if you have areas like in West Texas where vaccine rates are not high, there are a lot of kids and adults who can get infected. And again, we've seen that spread to other states. Because of this outbreak, we may very well lose our measles elimination status. So I think that's the last slide. And if you have any more questions, feel free to put them in the chat, and I will try to answer them at the end.
Wonderful. Thank you so much. Yes, please put your questions in the chat, and we'll turn our time over to Amanda.
Awesome. Thank you so much. Hi, everyone, and happy National Public Health Week. Today, I'll be talking about the messaging and content approach we've taken at the Public Health Communications Collaborative. So as some background, the Public Health Communications Collaborative is backboned at the de Beaumont Foundation. So if you're not familiar, we are a private public health foundation that supports advancing policy, building partnerships, and strengthening public health communications for the government public health workforce. So working at the intersection of these three different components, strengthening the workforce, thinking about ways that we can support them that feels really action-oriented and meaningful. So doing that through programs, research, and custom tools. All right. So to get in a little bit to the Public Health Communications Collaborative, click to the next slide. Thank you. This is a program that is very near and dear to my heart. I became director about a year ago of this collaborative, but it got its start before I got here. It's been around since August of 2020, and it is a joint partnership with the CDC Foundation, the de Beaumont Foundation, and Trust for America's Health. And the Kresge Foundation has come on in the more recent years to help support the project. We really grew out of a need for clear, concise communications from state and local health department officers that were trying to understand how can we go to a hub that provides us with this clear, concise information that is turnkey, that is relevant in communicating things like social distancing and hand washing and masking. And then eventually we did messaging around the COVID vaccine. And so really got our start during the pandemic to meet the needs of public health communicators and have since really grown our offerings and our partnerships beyond just COVID-19. So we do a ton of messaging on topics like measles, which is why I'm here today. We do messaging on the H5N1 bird flu, about 20 other different topics that have been flagged to us as needed in the field. And so the folks that we support are who we call our public health communicators. And so that can be someone who works in a health department at the state and local levels. So think of your PIOs, your comms directors, your social media managers. We also convene people in the field that are on the nonprofit side of things. We focus on schools of public health as a target audience, and we also see some folks following from the healthcare angle of things to turn to us in getting that clear and simple messaging on emerging health topics. So we've been this information and resource hub for over 5 years, and our goal is to really support the workforce so that they can support the well-being of their communities, and doing that through timely, science-based messaging and communication resources. All right. This slide serves as a snapshot of all of the offerings that exist out of the PHCC. We have a monthly webinar series if you haven't already tuned in, but we focus a webinar, we build one out every month, and it's focused on a topic of interest that we're hearing from the ground as something that people want to learn more about. The one we're doing this month is on podcasting and public health. So thinking about new media channels and platforms to engage audiences and maybe reach some new ones. So that should be a fun one scheduled for later this month. But our webinars attract upwards of 2,000 people from the community that are wanting to stay on for the full 90 minutes, hearing from subject matter experts in the space. So it's a great driver of new folks to our community, but also a way to stay engaged and to build that community. We also provide messaging around trending narratives that are happening in the space. So we do media monitoring to understand, okay, what are the misinformation and the rumors around public health topics that people need to know about? And so we kind of summarize the learnings in that week, and then we take those to help inform some messaging that public health communicators can leverage when they're speaking to their own communities about the misinformation and trending narratives that might be swirling. We provide multi-page messaging and communications resources, so messaging like how to effectively talk about vaccines in the post-COVID era, to communications resources on how to think about plain language when you're building out your communications materials, accessible social media communications, culturally competent communications. So working with subject matter experts in the field to expand that in a way that we can lift up their learnings and provide these really rich but condensed resources. I'll mention we have a newsletter that goes out every other week. We are active on LinkedIn, and so a lot coming out of the PHCC community in supporting the 40,000 people that follow us on a weekly basis. This is a snapshot of some resources that we have, but kind of recognizing the folks that are in the room and what you're curious about. I pulled resources that I think would be helpful if you ever want to check out later. We have a guide on navigating and combating misinformation for public health communicators. We have a multi-page guide on communicating more effectively about vaccines. So what are those new messaging frames and language to be leaning into? And then on the right-hand side is a one-pager checklist on best practices for plain language when thinking about building your communications for your audiences. All right, so the current context. This is data that I pulled from Google search trends. And so I searched for first off, within the last 12 months in the United States, how many people are searching for measles on Google? And you can see that it was very, 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 very flat. And then you can see this massive spike. So right now we are past that spike and it's continuing to kind of chart upwards. So the little dots are Google's prediction of how the conversation is going to continue trending. But the key thing you need to note here is that users and audiences are turning to the internet to learn about measles and to learn about, okay, what is measles as a 101? What can I do to protect myself? Thinking about the measles vaccine. And so just kind of highlighting that there's some really strong interest from communities across the United States that are wanting to learn more about measles, and the data really shows for it, this huge spike. All right, and so in response to that, we've developed a landing page on our website. If you scan this QR code, it will lead you to our topics page. And that serves as a hub where you're going to find, if you click on to the next slide, the following things. You're going to find related alerts around measles. And so what I mean here is on a weekly basis, we monitor the web, we monitor online conversations around measles. We see what is the trending misinformation and narratives, and how can we provide people with clear guidance on how to navigate that in their community? So we provide the summaries of what we're hearing, and if you click into those boxes, you can kind of see what is our recommended messaging in response to that. We have a couple of clear talking points on, first off, what is measles? How does measles transfer? What does measles vaccination and prevention look like? And what is the treatment? So those really clear things to be communicating to their communities. It's an opportunity for them to come to our site, get those clear nuggets and use it for social media graphics or infographics or newsletters, or even to brief their internal comms teams. We really want to keep this messaging very clear, very concise, and also recognizing the readability level of the US is between 5th to 8th grade. And so avoiding jargon, thinking about moving away from science-based messaging to moving towards messaging that feels more audience-centered. So I encourage you to check out the landing page to find those talking points, alerts, and recommended messages for measles in your community and how to talk about that. We also have a more dedicated resource on measles outbreak messaging 101 with overview on what are the top line messages to be leaning into based on research that we've done in the field. What are some of the supporting messages to be thinking about when you're building your communications plan? And then some communications considerations to keep in mind when you're talking about measles to your communities. So this is another QR code. It's different than the previous one, but this one will lead you directly towards the messaging resource that exists on our website. On the next slide, I wanted to elevate some that last piece on the last slide that talks about communications considerations. I think this is really important because when you're communicating around a topic like measles, it is really urgent. It's very top of mind. People have a lot of questions and concerns. And so when you're doing communications around measles, I would recommend just kind of considering these questions when you're developing those communications. First, think of your audience. This is a big one. Center yourself in what are their needs, what are their concerns, and what are their questions. Another one is, what do you want your audience to do with this information? And so in marketing, we frame this as the CTA, or the call to action. So as important as it is to be communicating the message to drive awareness of a situation, so measles is on the rise, here are the facts, it's also really important to remind someone of, Okay, here's the messaging, but what do you do next? Do you check a website? Do you call your doctor? Do you have a conversation with someone? It's really important to really stick the landing in your message to include some kind of action item for the person to be jumping off of. And the last I'll recommend is your local context. You're on the ground with your communities. You know their motives and their behaviors around topics. And so really rooting yourself in your community and the local voices and thinking of the nuances on how to best capture that into your communications message. So 3 key considerations when communicating about measles here. And remember, this is kind of best practices for not just measles, but for any public health message that you communicate. And I'm going to list it across these 3 key buckets. The first is, and I can't emphasize this enough, but using clear, concise, plain language. That means avoiding jargon, technical terms, breaking down complex information into digestible, actionable messages. 2 is building trust, acknowledging when you know something and when you don't know something. So say what you know and what you don't know. That saying what you don't know is just as effective as saying what you do know to help people know that you're on it and you're part of the journey with them and you will circle back. The third one is staying proactive and responsive. So continue to monitor misinformation when you're seeing it. Prepare communications ahead of time for rapid response solutions. So think about building out templates and structures and processes so that before a threat happens, you are prepared to communicate that and work on that with your communications team or also as yourself as a communicator. So 3 key things to keep in mind when thinking about messaging around emerging topics. And I think that's it. Thank you so much.
Wonderful. Thank you. So many great resources to check out and to help us as we are trying to prevent the spread of misinformation and to, urge positive messages. So thank you, Amanda. Okay, we will turn the time next over to Dr. Gambescia.
Great. So thank you, Amanda. This is a good segue. So you considered what Amanda said in the last 2 slides in terms of the consideration of the message and the 3 things to keep in mind. The channel where you would push this information out, I'm going to discuss as the op-ed or the opposite, the editorial. I'm drawn on having formal training in communications and very specifically in journalism and public relations. I teach health policy at all 3 levels, and I've written scores of op-eds in major newspapers. So starting with what is an op-ed? If you draw your attention to the upper right there, on the left-hand side, you see 3 words, op-ed, opinion, and commentary. An op-ed means opposite the editorial. So if you look at the fold as you read a newspaper, the editorial's on the left-hand side, and the op-ed would be commentaries and opinion pieces that you would have. So the term editorials is not used with a commentary or an opinion piece. The editorial is reserved for a group of writers of the paper. Sometimes it could be few if it's a local paper, or if you take a metro paper, it could be up to maybe 8 people who write their opinions, and then they open it up for other opinions. So it's about 500 to 800 words. Now, most of you are probably writers. 500 words is not a whole lot, so you really need to develop the skill in writing a commentary and an opinion piece in terms of that. They like to publish what I say things are salient issues of the current day, and they usually like to respond to things that are in the news of the day. Although you can resurrect and endure an issue, we certainly have one here in terms of infectious disease, but more specifically, there's definitely saliency today with the measles. It's written by a range of people who have credibility to opine on the subject. Sometimes Joe Schmo citizens, so to speak, can write a commentary, but usually they're people who had credibility in terms of subject matter expertise, sometimes a personal experience with an issue. And then this next bullet here, they are read by what I would call movers and shakers. It's not that the common person won't read them. And that's important because thinking about Amanda's comment, you can write at a high level here in a commentary and an opinion piece, although keeping your audience in mind. Most of them are serious. Sometimes they're lighthearted, but I would avoid doing that unless you really know how to pull that off. And some papers, for example, our Philadelphia Inquirer, I live in Philadelphia, they've eliminated light-hearted commentaries. Keep in mind, too, that when you're writing the commentary, you have to get past the editor. So I'll talk more about that in the next slide as we go on. So here's some basics that we'll go through, and I have them numbered. Step one, have clear in your mind what is the overall purpose. So these would obviously give opinions. You may be writing it to draw conclusions. Maybe you're stating some anecdotal information. You could be giving recommendations, suggestions. The next two are things that I work on. I'm a policy person, and my area is macro policy, where I like to connect the dots of multiple points that are out there, show relationships. Sometimes you may have to correct a fact. And then the final one is to incite, engage, motivate, and sometimes to entertain. But again, those areas of entertaining, I would avoid doing that unless you know how to pull something like that off. So steps two and three, I'm sorry, steps two here is uh, where would you write, learning how to write the basics, the must, the styles, and the novel contribution, the length of words, don't go over. Uh, the website of the newspaper will tell you some do's and don'ts for the types of commentaries they accept. They don't like they don't like commentaries on commentaries. They shy away from that. So anything news of the day they would talk about, that would be important. Where to send it? There's different formats that you use. Imagine in the old days we had to type these out and send them in. Today, most of the papers are allowing you to embed your commentary, your 500, 800 words, in the email. So you're likely to do an attachment. Sometimes I would do both just to cover my bases. And sometimes you would be doing it through a form, right? You would just populate that form with your commentary in there. Sometimes they'll ask you to give the context of the questions. What is your topic? Maybe a brief summary. And then why are you writing it? What is it about you? Now, watch that because that could change depending on your audience, where you're writing it, and what you're saying. So, for example, I'm a university professor, but if I have a local issue, I just want to be viewed as the common citizen or maybe an issue of importance in our community, which could be very small. It doesn't necessarily have to be a big city. It could be at the township level there. And then reread, and double check the guidelines. They're very important because the editors will be persnickety about that. Think about it, they get hundreds of commentaries a day, depending on how big the paper is. So now steps three and four. So with step three, very important to have your lead down. Really work on that and think about. There's many types, uh, but you really want to be able to capture the reader. If you get overly creative, that could be difficult. You really want to focus on, okay, what are you writing about? In fact, I just read a comment from a journalist who writes commentary that said 60% of my effort is finding the right lead. And that's very powerful. Think of the lead as a springboard. What do I springboard on? You can be very creative with this. And I've done this. You can use a news peg, but really be writing about something different. Example I would give is in the Philadelphia area, there was a movie, some of you may have heard about it, that profiled uh, Mother Cabrini, a religious nun who founded hospitals and schools, actually a college right outside of Philadelphia here. And the movie was very much about the power of one and the power of a woman who was a leader. And I used that in a springboard in actually two different ways, where I wasn't really talking about Mother Cabrini as much as issues that were related to women, that you can use that. So you can use these as opportunities as springboards. And the focus needs to carry you through the whole piece. We have a more expansive commentary or webinar on this that we'll talk about at the end of this webinar. Often what I will do is I will, as I'm ending the commentary, I will lead back to the lead. And actually, you could strategize if you have a decent headline, lead, then your body, and you kind of it takes some doing and some skill to come back to that lead at the very end as you're closing. Uh, and Amanda talked about at the end, what is your call to action is going to be very important. What's the overriding message? What's the call to action that you're doing? Caveat, you need to be disciplined in this. Avoid hyperbole, hackneyed expressions, rhetorical questions. I read a lot of student commentaries. It's very common that they're just going to throw a stream of rhetorical questions on there. And that Ask the AI assistant is hiding something called avoid ad hominem, attacks against the person, but I'll talk about that later too. Step 4, you will suggest the title, but actually in newspapers, printed newspapers, there's a separate editor who writes the title of the headline, and they're actually skilled in doing that. That relates more to the space that they have when they're writing the headline. But as an author, you would suggest one because that'll give the editor an idea of what the subject is. I would caution you against creativity. I know that's going to be hard because we have very creative people out there, but see, you have a little bit of risk with creativity. Uh, you can pull it off, but you want to make sure that the editor knows and the reader's going to know the point. So suggest a title, but in the end, the editor is going to give a title, and usually they're going to improve it. Definitely online, they improve it, but in the hard copy of the newspaper, they're constrained by the space that it is, the column and the width and those sort of things. So a step 5 that I have in this is, I'm sorry, next, okay, good question. Should I mention the opposition and recognize counter arguments? There's 2 schools of thought of this. Some people say, no, don't do it. Here's how I would look at it. It's the context, and use this as a good judge. The closer the controversy is, very divided and very strong on both ends, then I think it is useful to point out the opposition. But it takes some skill to do that. And if something is not really controversial, there may not be you may not have to bring it up. Example I would use when I was writing letters to the editor and commentary when Philadelphia was going through its banning the use of cell phones, handheld devices. I know we kind of passed that. I didn't have to bring up the idea that the phone companies would be opposing it because I had a sense that they weren't. Issues where you're going to have opposition, you may want to bring that up. And then the key is to be, you're trying to be respectful and understanding. So I would lead in with, I understand that certain people are opposed to this, or some people, this is a good one, some people believe something like that. So you always want to be respectful and don't give the other side to move to what we call ad hominem attack back on you as the author. This next slide is really an important one. Very unlikely you're going to hear about this, even if you read about this and people teach it. Consider the 1/3 rule in writing commentary. So I'm going to break this up into 3 1/3s. There's 1/3 of the people, when you write a commentary, they're going to agree with you no matter what you write, no matter how bad you write. They're on your side. That's really not the group you want to write to. Now, of course, we saw from Kathy's presentation, you want to have your facts right. That would be more embarrassing than anything. The middle 1/3 are people that you can convince or persuade to different things that you're doing there, convincing, so the cognitive or the action, and move them over to considering your side. Now, here's the mistake that I see a lot in commentaries, and oftentimes with university faculty who write them, that you don't want to insult the 1/3, the 1/3 who are not going to agree with you no matter what. But what you want to come away with is that they see you as reasonable, responsible, and respectful. So there are 3 R's. That's a good thing to keep in mind. You want to be reasonable. I'm thinking of Kathy's presentation. We have our facts right. You want to be responsible. Who are you representing? A health department, a university, a foundation. So that's really professionalism in terms of that. And then respectful is just a good thing to do. Um, and what happens, what I see is, and you need discipline for this, people go off script and they'll make an off the cuff comment that's really not necessary and really takes away from your commentary. So here's another tip. I don't have it on the slide. You don't want to distract the reader. Keep focused. And again, you need discipline on this. So an example was a faculty member that I saw was an academic, wrote this wonderful op-ed that explained, and you're going to recognize this group, the United States U.S. Preventative Services Task Force. Okay, that's a big group there. What does the public know about it? Why is this body important? And he wrote a really good commentary, but then went off skip like 3 or 4 times and just just made something that was pejorative about somebody, and it wasn't even necessary. So excising that is not going to be helpful. And keep in mind too is you have to get past the editor. So if the editor sees these slights, that they may not be as apt to run your commentary. These are the ad hominem arguments. You really need to be disciplined. It's a common mistake that I see. I mentioned you get past the editor, and on balance, they're just not helpful. Also, why give mic time to an opposition? I see this again in students' writings where they'll mention somebody who is not even related to the issue. I said, you're just giving them more mic time, as I call it. Okay, where should I send this? It relates to what we've been talking about. What's the message? What's the audience that you want to reach? And the adage that I use here, are we preaching to the choir, or are we trying to recruit the choir, or trying to recruit the choir there? Reach is obviously going to be important. We have your national newspapers, as you know, very difficult to get in. New York Times, Washington Post, LA Times, Boston Globe, Wall Street Journal, and Chicago, those big cities are there. Actually, Philadelphia, I don't know how many Philadelphians we have there. It's not a national newspaper. It's very regional today. Consider the practicality of the placement. Sometimes, too, is just getting something in writing, you can then use that, because once something's published, it can get legs, as we say in media, and you can start doing advocacy with something that you wrote. So you may have something in a local paper, but something hits nationally, and you can start communicating with. I send stuff to health department people. You can send stuff to journalists, and the power of something in print, people take that as a high regard. So we said there that all politics is local. So sometimes you may want to get something in a daily paper, sometimes even a weekly paper. Okay, clipping for success. This is something that I work with when I teach health policy with students. Stay current on the news of the day. Read credible metro and national newspapers. But today you're probably going to have to use a mix of them, because even the national newspapers have a certain bent. However, there's news of the day, there's commentary, and then there's the editorial. So I'm going to use the Wall Street Journal as an example. The Wall Street Journal is going to have editorials that traditionally are very conservative, but commentary are going to have a mix. And then in terms of news of the day, my opinion is I have a high regard for those news writers, and writing on issues very current. Workplace, things in public health, good science writers. There's only about 50 major science writers across the country. And then what I do is I actually keep files on these topics. Those of you who are more junior, over time, you're going to become interested in certain areas. You're going to build your files. Your files get bigger. Then you subdivide your files. And before you know it, if you're as old as I am, your basement is filled with files of news of the day. And that's when people, whether they're family members or associates, whatever, say, how did you know to write that commentary? I said, because I've been tracking this issue for 10, 15 years, and I'm able to, keyword here, I'm able to connect the dots, to contemporize something that I'm seeing. And oftentimes, I found you could be months ahead of what would be breaking. You could be writing commentary, thoughtful commentary, powerful commentary on things that are that later you feel really good to say, wow, I was kind of getting that out. I have a number of examples on that. So, final slide here. I'm going to take a breath. Write with passion, but you really want to balance this with humility. And keep in mind that the public's opinion of most of us who are going to be writing commentary, and I list the folks here, is plummeting. And I meant to put links to the public opinion polls that show this. And I know this may be tough medicine to take, but the expert class is one label that's used. Public health and health care, it's fair to say we've taken a hit in terms of the COVID-19 virus. Good, bad, or indifferent, it's out there. That's not new. University professors, I'd be the first to say, being one of them, that I'm very aware that the public opinion is shifting on us. And the media is, I was schooled, think about this, I was schooled in the mid 80s and learning hardcore journalism from the top people, AP reporters, Metro reporters, and a whole range of communicating from editorials, feature writing, news writing. But today, the writing's different. You have blogs, you have online, you have Facebook writing, you have social media, and you have TikTok and all those sort of things. I mean, I'm focusing a lot on the print media there. So avoid projecting that. What I'd like to say is we do good work. Uh, I like to tell students that when people ask you what business you're in, tell them you are in the business of improving the human condition. And they get a kick out of when I say they're either going to walk away from you or they're going to say, tell me more about that. But do we just be careful? I mean, I like to say, are we sitting in the side of the angels? You want to be respectful and you want to be understanding. And this issue, I'm not an expert in measles, but again, I'm very macro. You know that you work in this field. The people who are hesitant in this has expanded, really expanded. And think about the education level. Very highly educated people, vaccine hesitant, to people who traditionally we may see in public health. We just need to explain the knowledge base there. All different types of people that we're seeing in terms of that. And I think that's my last slide. Good.
Thank you so much. I mean, each of those things, that's a skill that we can develop, and one of the ways that we can promote healthy behavior and public health. So we have just a few minutes remaining. If you have any questions, please add them to the Q&A box. There have been a few that have come in, so I think we'll just answer those real quickly. Answers have been typed, but just as a brief recommendation. Amanda, can you tell us how you find trends in Google searches, just real quick?
Sure. Yeah. So there's two ways that PHCC does social listening and media monitoring. One is the free version where you can go into Google Trends and you can search by any topic or keyword. And what it's going to do is going to help you understand what is the volume of conversations, or sorry, volume of searches that are happening around that topic or keyword. And so it's pulling from search data. You can adjust by the different time frames. You can compare different topics to each other in one time frame. So I looked at measles and vitamin A over the course of 6 weeks and saw some really interesting shifts and trends there. The other service that we use is with a partner at we work with the Public Good Project. They're a nonprofit that does a lot of really great work in misinformation, and they have a dashboard that they use to help my team understand conversations that are happening online around not just measles, but really anything under the sun that is public health. So that is something that we opt into and pay for. But I'll also mention, I'm gonna drop it in my response in the answers, but we have this program at De Beaumont called Infodemiology. And so it's a 6-hour course on the study of information. And then as part of that training, you have access to this dashboard where for free you can filter by topic and see conversations happening at a state level, county level, available to you, no cost. So encourage folks check that out to understand conversations that are happening in their community around measles, but also other topics.
Okay, thank you. We're getting a few about measles specifically. So, Dr. Troisi, I think we'll have you answer these for us. One, can you speak to this question has been answered in the chat, but would you recommend that individuals get their titers checked or just go in and get boosters? And then, with your expertise, where can we find tracking information for measles by our city or county or state?
Yeah. So, you can get your antibody titers tested. It's expensive. I mean, we looked it up one time. It's like 150 to 250. Your insurance probably won't pay for it, but you can check. However, it doesn't give you a complete picture of whether you're immune or not, because we have two types of immunity, and the type that it's not measuring, cellular immunity, is more important in combating viral infections. So even if your antibody, even if you don't have any, you may still be protected. However, there is no downside to getting measles. If you're not sure whether you got it, if you can't find your records, or if you're going to be in an outbreak, you're traveling to West Texas or overseas to a country where there's a lot of measles. Again, there's no downside. As I said in my answer, my only caveat would be, and we're not seeing this right now, but if measles vaccine supply becomes low, you might want to think about it and saving, like we did with PPE at the beginning of the pandemic. Um, so, um, so yeah, no downside to getting another dose. In terms of where to go, first of all, I looked up. Texas has released today's numbers. They release them on Tuesday and Friday. 24 cases reported. We're up to 505, 57 hospitalized. The website is it's DSHS, Department of State Health Services, dshs.texas.gov. And then if you just say, you can just say DSHS and measles in Google search and it'll bring it up. CDC, just Google CDC measles, you'll get outbreak information. It's not updated as often. And there's some other caveats with the CDC information. Check with your wherever you are, your local health department, your state health department for specific numbers in your area, but you will find numbers by state at the CDC website. Again, may not be updated as frequently as local data.
Okay, thank you. And Stephen, there's a question for you. So this question says, with the growing disputing of public health information and medical knowledge, do you imagine future public health messaging and dissemination of health information working its way into opinion writing?
I think, well, it's already there. It would be already there for sure, and I'm finding it every day. So what I would do is where you're make sure that you're reading those opinions and finding out where it's there. And uh, there's a saying, people are very open. Newspapers very open to health data. There's an adage that we have: if it bleeds, it leads. Get in, and people are consuming this. There's another part of this too. Is it's important for practitioners. It doesn't matter if you're a practitioner or university. Certainly, practitioners to be reading all this, because that's what your consumer is going to be hearing and thinking about as they're consuming this. So I think now I have to say the traditional op-ed, this could be an opportunity, is I actually wrote a commentary on this. It's shifting a little bit. It's slowing up in some newspapers. For example, in Philadelphia, they're only running, imagine this, a major city, they're only running 1 or 2 op-eds a day. Usually they should be running 3 to 5
Yeah.
op-eds a day. But there are online commentary places that don't have to be, biased in terms of left, right kind of stuff, where they're open to you writing even longer pieces. I've done as much as 1,600 words, which is unusual, but they have been online. So for the folks in the room who know a lot about the new media, you have an opportunity to be using those avenues rather than the traditional avenues of online commentaries that you would be able to open to. Yeah. Hopefully that
Great.
answers that. I think it's going to remain important, and the opportunity could be you can be actually writing a little bit more.
Or maybe even taking it and using some of those skills in relation to social media posts we might create for the organizations we're working with too. So thank you. Our time is up. We have 2 more questions. If you need to leave us, we understand, but we do want to get these 2 more questions answered. These are for Catherine. So, which populations tend to be vaccine resistant? And with potential cuts to public health departments, will that affect the availability of the measles vaccine?
So let me answer the second question first because it's easier. Yes, we are very concerned about the cutbacks we're seeing. In fact, in West Texas, their teams, their money has been cut to respond to this outbreak. So yes, vaccine hesitancy is a really complex issue. And it used to be before Vaccines for Children program was implemented, which 70s, I'm not sure, I don't remember. Before that, it was poor children who tended not to be vaccinated. That's not the case now, as I believe it was Stephen said, that we're seeing children of parents who have at least a college degree, sometimes master's degrees as well, who are rejecting vaccination for their children. Now, in some countries and in parts of rural United States, there are also structural barriers. Maybe parents can't take time off to get their child vaccinated, time off from work. Maybe it's a long way. West Texas, it's remote. And so it may not be easy to get your child vaccinated. And with the second question, with these cutbacks, it's going to be harder to, because we won't have as many vaccine clinics. If you're overseas, the cold chain that the vaccine needs, it can be an impediment. War and conflict are big impediments to getting children vaccinated. However, in the United States, it's vaccine hesitancy, along with some of these structural barriers, but vaccine hesitancy, it's it's a personal choice, as Robert F. Kennedy Jr. has said. We are a very individualistic country. It may be we're not thinking about the community because the reason, we're vaccinating to protect the child, of course, but you're also protecting those other people who can't be vaccinated. There's a lot of misinformation out on social media. I would argue that our scientific and critical thinking education is maybe not where it should be. When you see, I always laugh during COVID where people said, "Oh, there's a microchip in the vaccine, and so the government can follow you." And I would say, "Do you have one of these? The government, anybody can follow you anywhere." And how would you even fit a microchip in there? It's just these outrageous things. But that points to the polarization. Vaccination has become an identity issue. It's very hard to change people's minds when you're part of a group. There's confirmation bias. And let me go back again to social media because this has played a big, big role in these groups. And so you're just getting information that confirms what you believe in. So that's a short answer to a complex problem.
Mhm.
Mhm.
Yes. Thank you so much for, answering that for us. I think it's an issue that many of us are seeing and in the populations that we are working with, whether that's, education or epidemiology or, in schools. And I mean, this webinar is for those mostly associated with school health and wellness and then public health education and promotion. And so these are big issues and using tools that we have to reach out to them and sharing our knowledge via op-ed pieces or other educational opportunities and, using science-based information is something that can help us do that. So Amanda had to hop off, but we'd like to thank each of you, Dr. Troisi and Dr. Gambescia, for joining us. And for those who joined as for this webinar, we thank you for joining us as well. This has been so successful, and we are just wonderful with that. It's wonderful to have you. That's what I meant to say right there. So we have been lucky to have you. We are going to be working on getting a recording of this webinar out so that that can be shared as well. And I will go ahead and put into the chat a link for the page where you can go to get the PDF to then get Ches credit, category 2. And I will put that in there right now. But thank you everybody for attending. And there we go in the chat. Sorry, trying to do a few things at once. But thank you again for your attendance. And we hope you have a great day. See ya. Thank you.
Great job moderating, Yvonne.
Oh, thank you.